We described the pharmacokinetic, pharmacodynamic, and toxicodynamic properties of antifungal agents. Now let's explain the pathophysiology and clinical presentation of candidiasis and aspergillosis. Now let's take a look at mortality due to invasive mycoses. Candida species typically cause the least amount of mortality, but still pretty significant. So 10 to 20% mortality rate in invasive candidiasis. And the rate of mortality goes up, especially once we get to the mold. So Aspergillus species, you get significantly higher, in the 40% mortality rate for a lot of patients. And that's because, these, as you go up the ladder, up the steps here, these infections occur as the level of immunosuppression increases. So, for most patients with intact immune system, these infections just do not occur. So these are mostly opportunistic. Mucorales, Fusarium, these are invasive molds. And especially when it's resistant, not only is the patient immunocompromised, but also antifungals may not be active. So that's why the rate of mortality goes off the roof. Now let's focus on candidiasis. So drug-resistant candidiasis has been a serious threat per the CDC levels of emerging threats. And you can see different species of Candida. So Candida albicans causes the most of infections, followed by, and this is specifically in the blood. In fact, candidiasis is a umbrella term referring to both cutaneous, mucosal, and deep-seated organ infections. Invasive candidiasis specifically refers to not only bloodstream infection, but also deep-seated infection. So bloodstream infection would be called candidemia, and deep-seated infections include things like intra-abdominal abscess due to fungal species, osteomyelitis, endocarditis, etc. Okay, so in the blood for candidemia, C. albicans causes the most incidents, followed by C. glabrata, and then Prostheses, tropicalis, and then the rest of them are pretty much low rate. Now, among healthcare associated bloodstream infections, Candida actually rank in the top 3 or 4. In fact, Staphylococcus aureus is number 1, and then Coag negative staph, and then between Enterococcus and Candida would be the next that cause bloodstream infections. And mortality is pretty high, so 10 to 20% mortality due to candidemia. And the most common individual risk factors include indwelling central venous catheter, exposure to broad spectrum antibacterial agents. So, another reason for antimicrobial stewardship is that in addition to all the other collateral damage, it also increases the risk of candidemia. Other risks include long-term ICU stay with or without assisted ventilation, recent major surgery, necrotizing pancreatitis, any type of dialysis, TPN, and of course immunosuppression. Now let's look at invasive candidiasis. So Candida colonization is regarded as a prerequisite for subsequent infection. So in fact, typically through the intestines. So people can be colonized in the intestines with Candida species as part of the flora. And then if somebody has peritonitis, for example, if they have surgery, any type of colon surgery, this can actually have leakage, and these Candida can find their way into the bloodstream and then cause candidemia. Another path could be, if somebody has a catheter for long term, through the catheter, these Candida species from the outside, if they're colonized on the skin, for example, they can find their ways into the blood and cause candidemia. And of course, you can also have, it's not uncommon, especially for women, to have vaginal candidiasis, and then you can have an ascending route. So from the bladder, the Candida can find its way to the kidneys and cause pyelonephritis, and then of course from the kidneys. It can easily go into the blood and cause candidemia. But regardless of how it finds its way into the blood, then the blood goes, of course, to every organ, and then it can infect other organs. And that's what we refer to as deep-seated candidiasis. So, for example, it can infect the spleen and cause abscess. It can cause the liver and cause abscess there. The eyes can often be involved, so it can cause some serious infections in the eye. Of course, the lungs can be, you can have abscess in the lung. And of course, osteomyelitis. Now let's take a look at how to screen and diagnose it. So of course, invasive candidiasis should be suspected in people who have those risk factors. So the risk factors are what will be screened in patients. Now it is estimated that about 15% of patients with candidemia have manifestations of ocular involvement. So it is recommended by IDSA to have a dilated fundoscopic examination performed by ophthalmologists. So anytime somebody has candidemia. When it comes to blood culture, it is important to note that Candida grows slower than most bacteria. So, when we have blood cultures for bacteria, typically we get the gram stain pretty much the same day. For Candida, it may take a couple days before we can even get the grams or any type of staining under microscopy. So that delays the process. And one rapid diagnostic that we have is the T2 Candida panel that can detect, not every Candida species, but it can detect 5 most common Candida, and it does report them in groups. So it might not be able to tell you exactly which of these 5 the patient has, but it says, one of the 2 in a group. And it can do it from the whole blood, so you don't have to wait for 2 days for it to grow. For the colonies to be put on this test, it can be directly from the whole blood. Now, outside of the blood, the diagnosis is essentially dependent on culture and or a positive histopathology from normally sterile sites, such as intra-abdominal or intrathoracic sites. Now, let's switch gear to Aspergillosis. So Aspergillus conidia or spores are ubiquitous in the environment, so they're everywhere in the soil and any moist material, especially material that are decaying, organic material. Now the primary route of infection is through inhalation. So pretty much most Aspergillosis infections are pulmonary Aspergillosis, although extrapulmonary Aspergillosis can occur, but it's not as common. Clinical manifestations of disease are largely dependent on host immune response. In general, Aspergillosis is broken into 3 types. So there is invasive Aspergillosis, for example, pulmonary Aspergillosis. There is chronic forms of Aspergillosis, and then there is the allergic form of Aspergillosis. We are going to focus on invasive pulmonary Aspergillosis in this course. Now, one thing that's important to understand about the pathophysiology is that once these Aspergillus species are inhaled in the lungs, once they start to grow, the Aspergillus hyphae may invade the pulmonary arterioles, and they can lead to ischemic necrosis, intravascular thrombosis, and hemorrhagic pulmonary infarct due to rapid hyphal growth. So one thing that you will see is, hemoptysis might be as one of the symptoms of pulmonary Aspergillosis. So essentially blood coming out of the lung. Here are the common Aspergillus species. So pretty much most of these are due to Aspergillus fumigatus for pulmonary Aspergillosis, as well as Aspergillus flavus. The rest of them are not commonly seen in the lung. So for example, Aspergillus niger is more common in burn wounds. Now, classic risk factors for aspergillosis include prolonged, profound neutropenia, so essentially absolute neutrophil count under 100, neutrophil dysfunction, hematologic malignancy, and hematopoietic stem cell transplantation, as well as prolonged glucocorticoid and immunosuppression therapy. And then these are classic, but emerging risk factors include critically ill patients, so anyone in the ICU, COPD, solid organ transplantation, HIV infection, and viral co-infections such as CMV, influenza, and most recently SARS-CoV-2, and of course liver disease. So symptoms of pulmonary aspergillosis include dry cough, shortness of breath, chest pain, and hemoptysis. Patients can be pretty ill with tachypnea, tachycardia, and hypoxia. Now, fever may or may not be there because typically patients who get this, they're already immunocompromised. So because they're immunocompromised, they may not be able to respond with the fever. So that's why fever might not be there. Now, the gold standard for diagnosis is histopathology, examination, and culture of a surgical lung biopsy. Now, we do have a couple of assays, so Galactomannan and β-D-glucan, that can be detected in some patients with invasive. However, they're not, very specific. So, they could be positive due to other fungal infections, but this is something that can be used to, for example, see if the patient is responding to antifungal therapy. Now, this is just FYI, but something that's classic about aspergillosis is that on a CT imaging, there is often the halo sign that, people talk about on rounds. So when you hear the halo sign, essentially they're looking at a CT imaging, and that's what they see. And that's essentially a central nodule surrounded by ground glass opacity that represents the hemorrhage. And then another thing that you will see 1 or 2 weeks later is the air-crescent sign, and that's essentially the retracted and infarcted lung.